Thank you very much, Dr. Brian, for that excellent talk on the expanding field of atopic dermatitis management. You gave us a great overview of new treatment, especially for patients with moderate to severe atopic dermatitis. Now we will move on to a discussion on how and when to consider these new treatment options across different age groups, as well as other important factors influencing treatment decision, including safety consideration. Let's begin with our first question. The first question is, what do you consider transitioning from topical to systemic therapy in patients with atopic dermatitis? Do you apply different threshold for the following age group in adult more than 18 years, in adolescent 12 to 18 years, or in small children? Dr. Sila, please start with this question.
Okay. Thank you to Ajahn Sriwan for introducing, and also thank you to the organizer of this event as well. So regarding the question, I would just like to propose to show you the Thai clinical practice guideline about the treatment of atopic dermatitis, especially when you want to transfer from the to the systemic therapies. So in the Thai guideline, we separate the recommendation for the long-term treatment, especially in adults and children and adolescents. So from this presentation, you can see that we consider the systemic treatment when the patients have severe lesion, and the severity of the lesions can be classified by the EASI score or SCORAD score. And the list of the systemic treatment that we recommended in the Thai guideline, including the UV as well, apart from the immunosuppressive agents, as Dr. Brian mentioned earlier. But we also include the MMF, which is a mycophenolate in other guidelines as well, even though it's not great in the evidence of treatment. In Thailand, it's already approved for the dupilumab and two of the JAK inhibitors for adults, and also for the next slides, I'm going to show you the children and adolescents, which is basically similar to adults, apart from the indication for UV phototherapy. So for the next slide, please. Yeah. So we have the limitation for the use of the immunosuppressive already, because the duration could not be that long, especially in the immunosuppressive agents, for example, cyclosporin or the methotrexate, because these can lead you to the side effect of treatment. So we have the recommendation for the use of the JAK inhibitor and dupilumab in severe atopic dermatitis, that they must have the atopic dermatitis for longer than 1 year. And the EASI score should be more than 20. The disease should be uncontrolled with the medium to high dose topical steroid, and at least 2 of these systemic therapies that I show you in the next slides. Yeah, so this is the list of the recommendation for each of these systemic therapies and the period that we suggest to use if it fails over, for example, azathioprine for over 12 weeks. We don't recommend to continue, or we suggest to look for the another treatment, for example, JAK inhibitors or dupilumab, which have the safer profile. So for the non-immunosuppressive, which abrocitinib, baricitinib, or dupilumab in Thailand. In next slides, I can show you the diagram for the use by the age of the approval in Thailand. For example, abrocitinib is approved in the age over than 12, baricitinib in the age over than 2, and dupilumab in age over than 6 months. And we evaluate the response of the treatment at 16 weeks after the beginning of the treatment by looking at the EASI score should be decreased over 50%. And I just want to raise the issue about the safety of these medications as well in the next slides. So this is just the dose of baricitinib, for example, in each age group, and also just by the weight as well, and the ones who may have the renal insufficiency. We also recommend looking for the safety profile for the patient in the next slides. So basically, we suggest to screening for some infections, for example, tuberculosis, renal and hepatic function before, and also CBC. So looking at the number of neutrophils, lymphocytes, and during the continuation of the use, we also recommend to check up about the CBC and also the risk for the safety profile. So I think I just want to briefly show you about the Thai guideline. Thank you.
Thank you very much, Dr. Sira, for your thorough flow for patients in different ages. And now, can I invite Dr. Grace kindly tell us when will you use systemic therapy in AD patient in Indonesia, please? Dr. Grace.
Thank you, Professor Siriwan. Good evening, everyone. I'm truly honored to be part of this event and to have the opportunity to represent my country in sharing my clinical experience in managing patients with atopic dermatitis in Indonesia. In Indonesia, we only have systemic medications such as corticosteroids, cyclosporin, azathioprine, and the newer generation drugs, baricitinib and abrocitinib, and no biologic treatment approved yet. The Indonesian Dermatology Association or PERDOSKI guideline was updated in 2023, has included JAK inhibitors for the adult treatment of moderate to severe AD after failing with conventional treatment. Abrocitinib and baricitinib are approved for patients more than 18 years old. However, baricitinib is expected to receive approval from the Indonesian Drug Regulatory Agency for pediatric use in the near future. My considerations were largely aligned with those of Dr. Sira when determining the appropriate timing for transitioning from topical to systemic therapy. But in addition to referring to the Indonesian guidelines, my general considerations, regardless of the patient's age, are first, inadequate response to topical therapy, meaning the patient shows persistent symptoms despite optimized topical treatment. For example, I already gave them corticosteroids, topical corticosteroids, calcineurin inhibitors, emollients used correctly for at least 4 to 6 weeks, or frequent flares requiring repeated courses of topical corticosteroids. My second consideration is the disease severity. I switched from topical to systemic therapy for moderate to severe AD based on the EASI score more than 16, the body surface area involvement more than 10%, Beer pruritus, the itch scale more than 7 out of 10, the marked sleep disturbance that impact the patient's quality of life. My third consideration is the disease location. I usually give systemic therapy if there are involvement of sensitive or hard to treat areas, for example, face, eyelids, genitals, hands, that limit the use of topical corticosteroids due to risk of side effects. Another consideration is impact on quality of life. If there is significant impairment in their daily function, school or work productivity, or mental health. As we all know, in infants and young children, AD can severely disrupt sleep, feeding, and development, and also create emotional and physical burdens for caregivers. In adolescents, disease can cause significant psychosocial stress, affecting self-esteem and social life. My last consideration is contraindication or side effects from topical therapy. If there is already development of tachyphylaxis or adverse effects, for example, skin atrophy from long-term use of corticosteroids, or non-adherence due to fear of corticosteroid side effects or steroid phobia. But I agree that age is also crucial in the decision-making process for systemic therapy. We have to choose age-appropriate and approved therapies, evaluate safety, efficacy, and psychosocial impact, and in some cases, we have to involve pediatrician when treating young children. I think that's all my opinion.
Thank you very much. A very good point from Indonesia. Now let's move on to the second question. What are key factors that impact treatment selection? May I start with Dr. Sila, please?
Okay, absolutely. Well, I mean, first of all, we have to ask about the price because the price of the medications, as Dr. Brian just previously mentioned, with the conventional immunosuppressive is low price, but it comes with a side effect for sure. So I think when we have to discuss about this with the patient, whether they can accept about the side effect of these medications or not. If they cannot really accept this, or they have a risk of developing the side effect of these medications, so we might have to go for the safer options like JAK inhibitor or dupilumab. About these two medications, I mean, it's completely different because one is the oral form, the other one is the injection form. So, I mean, in children, I have to say that the most common of the side effect of the dupilumab is the site injection, which is a bit painful. So I think in young children, the parents or the children themselves are really concerned about this, and especially in some who might have the needle phobia as well. The other impact is the comorbidities. I am in allergies, so I'm seeing the patient with multiple allergic diseases like asthma or allergic conjunctivitis, for example. So for asthma, maybe there may be stronger evidence in terms of for the use of the dupilumab when compared to the JAK inhibitor. But for some other diseases, there's no evidence yet. So I think we have to think about multiple factors that I just mentioned. Thank you.
Thank you very much, Dr. Sila. May I invite Dr. Peter for more factors that may impact treatment choice?
Thank you, Prof. Sirwan. So I think just now Dr. Sira mentioned about the dosing. I think that is very important because like for JAK inhibitor, we can take orally. And therefore, we can adjust it. In fact, I use it sometimes as a rescue treatment. That means when the patient is very well controlled, I taper off the medication, and when necessary, then I restart back. For example, patients who have this periodic flare, some patients during certain season or during certain stressful period, like exam periods, they get a flare. Then that's the time when they use the rescue treatment. And nowadays, I think more and more JAK inhibitors came out with all these studies on who are the patients that we can possibly stop the JAK inhibitor, who are the patients that we think we may need long-term treatment. So I think in future, it's easier for us to use this medication targeted to these populations. And when we talk about safety and tolerability profile, okay, no one is saying that JAK inhibitor is all good, it's all safe, but we know that it has long-term safety data there. For example, like for baricitinib in rheumatoid arthritis group, we have a long-term study up to 9.3 years showing the long-term safety. And in the atopic dermatitis group, for adults, we have up to 3.9 years study, and pediatric, we have up to 3.6 years. For UPADA, we have up to 5 years, and abrocitinib up to 144 weeks. So we are very fortunate in Malaysia that we have all these three JAK inhibitors available. We have used all of them. And definitely some JAK inhibitors, they have their specific side effect profiles. Like, for example, upadacitinib. If I see that the patient has a lot of acne, non-cystic acne, that may not be the one that I want to choose upada for, because we know there's slightly higher risk in terms of getting acne in this group of patients. And biologics, I use a lot as well, especially for those patients like Dr. Sira mentioned with multiple comorbidities in the elderly, that or in patients who I cannot monitor the blood in those multiple comorbidities like heart failure, stroke patients, then maybe those are the patients that I would prefer biologics over JAK inhibitors. And let's talk about what about MACE and venous thromboembolism risk, you know? Can we have the next slides? Yeah.
Oh,
So
I think
yeah,
that we're going to talk about it later. Could I just stop at this time and then
okay.
I go to another question? I know that you have a lot of information about JAK inhibitor, but let's go to the other question first. And for patients or caregivers who are planning to start oral systemic therapy, whether conventional or JAK inhibitors, we know that it affects their life. How do you provide counseling on blood monitoring requirement for before and during treatment? Let's start with Dr. Grace first.
Thank you, Professor Siriwan. In Indonesia, dupilumab injections are not yet available. But thanks God, if they were, it might be even more challenging to persuade children to receive this injection. As I mentioned before, in Indonesia, we only have systemic medications such as corticosteroids, cyclosporine, azathioprine, and the newer generation drugs baricitinib and abrocitinib. Patients or their parents often express greater concern when I request laboratory examinations before, during, and after treatment, particularly if I explain that the purpose is to monitor for potential adverse effects of the medication. This may lead to apprehension that they are being subjected to an experimental drug with unknown long-term safety. Therefore, I generally adopt a more subtle approach by explaining that I would like to ensure the patient is in good health prior to initiating therapy, including the proper function of the kidneys, liver, and other vital organs. With this reasoning, patients are typically more receptive and willing to proceed with the laboratory tests. And with this approach, parents are usually more willing to make an effort to persuade their child to undergo laboratory testing.
Thank you very much. And how about Dr. Sira's opinion?
Okay, for the conventional systemic therapy, there are already a lot of the safety profile that you have to check before and also during the treatment. And each of the medicine, for example, azathioprine, they might cause the anemia or the low lymphocytes or low white blood cell as well, or even the platelet decreased. So they have specific adverse events for each medicines, especially the kidney and the hepatotoxicity. So I think we have to close monitor when we are using the conventional immunosuppressive. For the dupilumab, which is available in Thailand, but we have, I personally have a very, very difficult time to start the treatment, especially even in the young adolescents or teenage, because of they didn't expect the injection site irritation that much. So for the second dose, it's going to be more difficult. And you have to apply this medication quite often. So I have to encourage the children to come to the clinic and have the injection. It's quite difficult, so it's going to take time. You can use the numb cream, apply before, but you also have to monitor for the common side effects of the dupilumab, which is the conjunctivitis, which is commonly found for the treatment in atopic dermatitis. And also they might have some blood eosinophilia as well after the treatment. Regarding the JAK inhibitors, I would say before the treatment, I already mentioned in the Thai guideline that we have to check about the tuberculosis, especially in Thailand, because I believe in Southeast Asia as well that prevalence of tuberculosis is quite high. So we have to check about the tuberculosis status and also CBC and the liver function and the kidney function. During the treatment, I would say the blood count, complete blood count, and the differential, looking at the number of the white cells and the liver function. But we don't really have to do that often. I would say 3 to 6 months if it saves, and then it's going to be fine. And other than that, in adult, maybe looking at the lipid profile as well, because there's a report of the abnormal lipid level after the use of the JAK inhibitors. So I think that that concludes all of my concerns about the safety profile and the counseling as well.
Thank you very much, Dr. Sira. And now come back to Dr. Peter regarding the new systemic agents approved in recent year. What does the long-term safety data show in dermatologic condition?
I think when we talk to the patient about side effects of JAK, the biggest concern that everyone has is regarding this thromboembolism, venous thromboembolism side effects, the major adverse cardiac events. I think because of the black box warning, but we have to understand that this warning comes from tofacitinib group that is being used to treat rheumatoid arthritis, not in our atopic dermatitis group. Because when you look at all this long-term safety data on various JAK inhibitor, you find that the major adverse cardiac events and the venous thromboembolism risk of this group are equivalent to the population, the general disease population untreated with JAK inhibitor. So we know that it is different group because in our atopic dermatitis, majority of the patients are younger patients with no comorbidities compared to the rheumatoid arthritis patients, bedridden with multiple comorbidities, right? Okay. And when we talk about malignancy and non-melanistic skin cancer, we can also find that the incidence rate is the same in general population versus in the populations whereby the JAK inhibitors was being used to treat those atopic dermatitis group.
Thank you very much, Dr. Peter, for your information. And I would like to add a quick point on growth concern. As you know, that the patient that got prednisolone or other classic immunosuppressive will have growth retardation. So this is another important information that they look at the patient that exposed to baricitinib at about 122 weeks. That's more than 2 years. The left graphs show the percentile that even they got exposure to baricitinib more than 100 weeks is still in the baseline height, weight, and basal body mass index percentile. And the right graph is the mean weight percentile. It's pretty much the same. So it means that from Dr. Peters' information is that long-term safety data clinical study report the incidence of major adverse cardiac event and also venous thrombotic embolism for the treatment with JAK inhibitors are lower with the background incidence of population with the same disease. And the fact that Dr. Peter have told us is that the age of the patient of atopic dermatitis are younger than patients with rheumatoid arthritis, so the incidence is lower. And for my point of view is that there's no impact on growth velocity by 122 weeks after they're exposed to baricitinib. And now come to the next question. How do real-world data reflect the outcomes of this therapy in heterogeneous group of atopic dermatitis patients? Dr. Brian, please.
Thank you so much, Professor Sirwan. So we're going to shift gears towards real-world evidence because when we discuss clinical trials, it's a really controlled environment. But what we want now is real-world, what's out there. So what's applicable to your country, in your clinic, in your patients. So these are very important data wherein you can see your different countries involved with these real-world registries and evidence. You can see similar data in terms of age and disease duration based on your BREEZE trials. And you can see also your patients are quite severe at onset. So what you want to see also is that how they improve based on easy scores. So is there like 50% improvement, 75, 90, and also the itch NRS. So what you can see in different countries like in Japan and Germany, you can see really good, important capture in terms of easy 50 and 90. So what you want to understand also is the symptoms. We don't want to discuss always your patient's easy score, but you want to also assess how you change the patient's lives based on symptoms such as itch. You know, in patients with AD, it's unbearable in terms of itch. So if you can see here at baseline at 7, you can see that at 2 or 3, remarkable data when you always see those numbers. And also in terms of your BioDay registry in Netherlands, you can appreciate also that most of those patients under these registries have used previous immunosuppressives and also dupilumab. So 75% of these patients were in dupilumab. And you know, whenever we treat patients with psoriasis and biologics, the best biologic is the first biologic. Because whenever you persist your patient with another biologic, it goes down. Remember, bio-naive versus that of the bio-experience. It's so hard for us to control PASI score if your patient is bio-experienced already. And that doesn't mean anything whenever you're going to shift your patient from biologic to small molecules such as JAK inhibitors, because there's no immunogenicity as well. So whenever you have recapture data, for example, for severe flare-ups for biologics, when you shift that for small molecule JAK inhibitor, for example, your baricitinib, you have a really good recapture. So I think this is a very important data. It's not only based on the easy score, itch, but really the recapture data, especially if your patient was on biologic or other immunosuppressive. Whenever we proceed to the next slide, which is on the safety, we have been discussing also in terms of all the infection and also all the malignancy discussed by biologics. But now here also in the real world evidence based on baricitinib use, we can see no serious adverse event. There's no new red signals. No reported data from Germany and Taiwan. Taiwan has really excellent data also. Whenever you have like adverse events, maybe mild, just urinary tract infection, nausea, herpes simplex, or maybe in terms of zoster in Japan, now we have really good data on vaccines as well. There are a lot of questions about vaccines. We can discuss that further on later on. So back to you, Professor Siriwan.
Thank you very much. And now it's time to show the clinical pictures of patients that got the baricitinib. I will start with Dr. Grace about her experience in baricitinib in atopic dermatitis. Dr. Grace, please.
Thank you, Professor Siriwan. This is my disclosure. Next slide, please. And my disclaimer. Next slide, yes. My patient is a 39-year-old male with a long-standing history of AD since childhood, and the patient eczema had shown significant improvement during a 10-year period living in Australia. However, upon returning to Indonesia, he began experiencing frequent flare-ups, which progressively worsened, particularly after he began playing golf twice weekly. The patient had consulted multiple dermatologists and undergone various treatments, with corticosteroids being the primary modality. While temporary relief was achieved, the condition remained relapsing and persistent. The itching was severe, significantly affecting his sleep quality and occupational performance. He expressed concern about the recurrent nature of his eczema and a strong desire to avoid long-term dependence on corticosteroids. Next slide, please. These are the baseline photos of the patient prior to treatment with an EASI score of 32 and an itch scale of 8 out of 10. As is common in adult face AD, the majority of lesions were located on the face and neck. The most bothersome lesions for the patients were those on the forehead and eyelids, especially when playing golf and exposed to sunlight. And after discussing available treatment options, the patient consented to initiate baricitinib therapy. Next slide, please. These are the pictures of the patients at week 3 of therapy. Clinical improvement was noted early in the course of treatment with EASI score 5 and itch scale 1. And the improvement was particularly in the facial and neck regions, and the pruritus was markedly reduced. Next slide, please. And these are the pictures of the patient at week 6 of therapy, and the patient reported a marked improvement in quality of life, with EASI score 3 and itch scale 1. My considerations for initiating systemic therapy and baricitinib in these patients were a long-standing history of AD with frequent flare-ups, the patient's reluctance to use oral corticosteroid again, the disease severity with EASI score of 32, the severe pruritus and body surface area involvement more than 10%, the presence of lesion in hard-to-treat areas such as face and eyelids, the significant impairment in daily functioning and work productivity, sleep disturbances, and psychosocial stress. Pre-treatment laboratory evaluations were within normal limits, and to date, no side effects have been reported by the patient or observed during clinical examinations. Thank you.
Thank you very much for your impressive case. Now I will share my last case. This is an adolescent, 15 years old girl with a long history of atopic dermatitis. The patient was diagnosed with AD at a very young age. Her treatment history includes the use of topical steroid, antihistamine, and regular application of moisturizer. During the period of severe flares, she was treated with oral prednisolone. In the past 3 months, her condition worsened significantly, leading to intense skin lesion and sleep disturbance. She reported some nights she cannot sleep at all. Due to the severity of her symptoms, she independently purchased clobetasol, which you know that it has a lot of side effects. But she told me that it is the only one that can manage her skin disease. And look at her skin, and with the side effect, her IGS score is 3. This is Investigator Global Assessment Score, and she rated her each 10 of 10. Sometimes we use score at an EASI score, but I think that mostly in research. But some doctors are really nice. They have time to do the scoring of the system. But for me, usually I do just investigation global assessment score because it is validated. It can represent the EASI score and SCORAD, which you have to use at least 5 minutes to do the scoring system. So this patient has clearly perceived erythema and clearly perceived induration population and clearly perceptible lichenification. Some lesions can have oozing and crust. I discussed with my patient, like other doctors, emollient already use aggravating factors or already avoid patient education and education until they don't want to listen to us. And she used a lot of steroid and already go to oral prednisolone. She don't want the classical immunosuppressive because she read a lot and she know the side effect of cyclosporine, azathioprine, methotrexate, as we have discussed. And she don't want any injection. She say that it hurt my skin so much and I don't want to hurt anything to hurt my skin. So she choose JAK inhibitor. At that time, we just have baricitinib in our country. I told her that we need blood tests. We need to screen for tuberculosis. She said she more than welcome if it will make her skin better. And so we do the testing and like Dr. Grace case, no side effect at all. At the very first, this is her skin. She tell me that after 1 week, the itch is very, very good. She can sleep very well. Even you can appreciate that the skin lesion is a little bit better, not very much, but the itch is very good. She can go sleep like 8 hours a night, which she never have. And after 6 weeks, the skin lesion really good. She have no itch at all. And after 10 weeks, you can appreciate that the skin lesion is much, much better. And after treatment of 1 year, she has a very beautiful skin, but you still can see that the stria distance turned into stria alba, but still there. Right now, she can stop baricitinib for more than 1 year. It's not all the case, about 30% of the case can stop, but she is very lucky. She have a proper skin care and she use my topical steroid only when flare. I just want to tell you that this is another case that is impressed me, and she also can stop the baricitinib right now. I think that we should go to the Q&A session. There's question from the floor. The audience have 3 questions. I want to at least 3, and now it's like 7, but we have to keep our time. The first question is very interesting. What is the recommendation about giving vaccine to young children who are on baricitinib or dupilumab? Any study related to this so far, and what is your practice? I think Dr. Sila can tell us because he's the pediatricologist, immunologist.
So I have to say that the regarding the live vaccination, live vaccine, I mean for the dupilumab, it's quite safe because it's just a very, very specific mechanism, especially involving the IL-4 and IL-13. So I mean, in general, even there's no safety data, but from the real world data or the phase 3 data, it's quite safe, but it's not generally recommended. But if it's really, really necessary, you can consider the live vaccine case by case, but you have to discuss with the patient as well. Regarding the baricitinib, I mean, if it's scheduled for the live vaccine and when you're about to start the baricitinib, you better to give the vaccine at least 4 weeks before starting the baricitinib. And during the patient was on the JAK inhibitor, both for the baricitinib or abrocitinib. In general, we don't really recommend to give the live vaccine because it can suppress the immune. So the live vaccine may cause the infection. If it's really necessary, we suggest to stop at least 4 weeks before starting giving the vaccine, and it's better to wait until 2 to 4 weeks again after the vaccination to restart the JAK inhibitor. But again, there's no studies. I mean, this is just a general recommendation. I think it's already included in the package of each medicines already.
Thank you very much. And the second question, may I ask Dr. Grace that do you use systemic treatment off and on when there are systemic flare? How do you ensure there's no rebound when taking the patients off systemic? Dr. Grace, please.
I usually monitor the treatment for a few weeks with one type of medication first. For example, with baricitinib, I typically continue the therapy for about 4 months before evaluating its effectiveness and deciding whether to switch to another treatment.
Okay, thank you very much. And the third question is for Dr. Peter. As you have many options available in Malaysia. What are the key factors that influence your choice on systemic therapy?
I think if we talk about the newer generation, of course, the older generation, it comes with higher risk factors there. So it's about, at the end of the day, it's about affordabilities, right? Those who can afford, then we group them into the biologics, the JAK inhibitor groups. Right? Now, between the biologics and the JAK inhibitors, I think the previous speakers have elaborated very thoroughly about injectable, whether patient have needle phobias or not, comorbidities and everything. So I think the thing that I can add on among the JAK inhibitors, right, among these three JAK inhibitors, how would I choose for the patients? Number one is the age, right? Because baricitinib has the advantage of being approved for 2 years old and above, whereas the rest of the JAK doesn't have. So between 2 to 12 years old, I tend to use baricitinib over other JAK inhibitors. Then for every single specific JAK inhibitors like upadacitinib, as I mentioned just now, high risk of acne, and whereas for abrocitinib, high risk of nausea, their GI symptoms is higher. So I always tell them to take the first thing before they go to sleep, the first few doses. It can last for up to 2 weeks. Now, the good thing about having all these options is one medicine doesn't fit all. There will be patients that respond so good with Barry, so good with Upada, so good with Abro. Now, if one doesn't work and we have, give them a good duration of period to try out that drug, it doesn't work, switch to another one. Or if the dose allows you to increase, because like certain, even, I know Barry from 2 to 4, Abro from 100 to 200, Upada from 15, you can go to 30 milligram. So if you optimize the dose and it still doesn't work, then you can switch to another different JAK inhibitors. Yeah.
Thank you very much. Very good point. And another question for Dr. Peter. In your experience, when and why do you decide to discontinue your patients on JAK or biologic? I mean, discontinue.
I think the most important factor is always the cost, right? I think all patients, right, because it's relatively costlier. So of course, if we can stop the medication, who doesn't want to stop the medication? In what situation would I consider stopping? When the lesion has cleared. I always say, if you leave some eczema behind, I always tell them, imagine like your house is on fire. The first story is there's no fire, but the basement there's still fire, and then you stop it, very soon the fire is going to restart back again. So I generally tell them we extinguish all the fire first, including there's no itch, no lesions. Then let's talk about tapering down the medication. Now, just now I briefly mentioned that certain biologics, certain JAK inhibitors, they've came out with the studies that show that, for example, if a patient have underlying previous systemic agents or previous allergic rhinitis, or at the onset of disease, there's already very extensive atopic dermatitis, then those are the patients that you may not be able to taper off the medication or stop the medication that fast, as compared to those who doesn't have. So they even have scoring methods if it's lower than a certain number of scores. So those are the patients that I may consider stopping it earlier compared to others.
Thank you very much. And the last question for this time, I will ask Dr. Brian, with regards to monitoring of fasting serum lipid profile and patients on JAK inhibitor, that is the lipid markers that we're monitoring, what is acceptable and what is impairment of the lipid profile would make the expert consider to modify the treatment?
Well, you're gonna do the baseline test and also after 3 months. So 2 or 3 times of that on the baseline, I'm gonna be weary. Also in terms of the lipid profile for your patient. But again, in terms of this medication, it's not like indicated really to stop immediately your medication. You can go down titrate and ask your patient if he or she has been living like very good with their food. So diet modification should be improved as well.